That is that's a big question. I think the best way is to use a consistent framework where there is rigor in how you assess the need for change, uh, look at acceptability of change and the capacity to change, and then to measure how much we've changed. And what is different from implementation science compared to outcome studies is that we assess the care delivery process, and our outcomes center on how well or how completely we delivered that care according to the metrics that we wanted to change. Whereas outcome studies will look at the effect of that change on standard patient outcomes, such as mortality or morbidity. Let's take a common care process. Women get diagnosed with early stage breast cancer. They undergo shared decision making with their clinician, and they make the choice of breast conservation surgery or mastectomy according to clinical desires and their values. For example, the value of keeping one's breast versus the peace of mind of taking it all out. However, in order to make this decision in the most informed way, women need the results from genetic testing or BRCA testing, which might influence their choice of surgery. But in many practices, genetic testing results are often received after the surgery has taken place, which in some instances require re-excision or mastectomy among women who have initially chosen breast conservation therapy. From the outside, it looks like, well, of course, it needs to happen just before they have their surgery. But in fact, when you look at individual practices, the reason why they are not able to deliver this care in the appropriate time point may be different. In service A, they may not have enough genetic counselors. In service B, they might send out their genetic testing to a lab that is always backed up, and delay in returns are external to that service's control. And in service C, it is possible that they have enough genetic counselors and they are able to do the testing in-house, but frontline staff may miss checking that test box early in the process, early enough to get the results at a time that would be meaningfully informative to the patient. So you can see that for each of these services, the appropriate service improvement intervention would vary depending on what the core issue is. And this is the essence of implementation science, to understand the specific processes within each service that contribute to a particular service delivery failure, and to develop a pragmatic and site-specific intervention using a standard rigorous framework for implementation delivery. That's a big question. One of the biggest challenges is the challenge of conducting implementation in a rigorous manner. Often when we approach quality improvement, we see a very specific problem, we develop a solution to that specific problem, and then we implement it. Often we may not necessarily know if that is the right intervention, the acceptable intervention, or if it's intervention that we can sustain over time if the champion for that intervention leaves, for example, if it's a resident. So one of the goals is to consistently use a framework against which all implementation interventions can be judged, so that a practice can decide which implementation process they would like to invest their energies in, because there are many competing services that would need to be enhanced. With regard to de-implementation, there is a perception that uh, patients are getting less or that we clinicians are giving less, when in fact, many guidelines, for example, NCCN guidelines, will recommend it will recommend aligning the treatment, aligning the aggressiveness of the treatment with the expected benefit at the patient level. And it's important to approach de-implementation not as taking something away, but as being able to optimize or personalize the regimen according to the patient's needs, values, and clinical situation.